Dr. Hanifa, are we ready for the next speaker?
صح. شد الحالات اللي يشتغل فيهم دكتور حسن فانه فول اب بتاعنا فيري اكسلنت كويسين يعني يعني حتى الابد يا ريت يعني مقارنة كثير في الأردن ولا في مصر.
لا الاستسمنت مش كلها ايبونيك
لا قلنا الاستسمنت والمراي هو المراي هو المليح هو المراي لازم نديروا حل المراي هذا بس نبدأ نديروا لهم
اسمها الريجرجيتنت فراكشن هذا كانت ميجر باي هذا فوليوم 150 كريتيريا فوليوم متر سكوير هذا سكان بعدين سيمبتومز ولا سيمبتومز فري
لا طبعا مش اللي خلق كثير هي بس سيمبتوماتيك
انا بشوف في حالات وايد بس ندز فيهم برا انتم مش عارف ندز في حالات وايد في ميلانو مش بتاعت حسن اذا حتى حالات من تشوف حالات وايد
أنا دكتور حسن ده بس التأهيل الصرفي
بس مستحيل ما فيش
في عندنا شوية difficulty في الكونكشن على زوم.
خلي الدكتور عطاف يعطي بخاطر التو.
Yes, this is what I'm doing. He will do it.
Okay. So we have few questions ولا لا؟
Yeah, if you can make another one or two.
Okay. Otherwise, we'll ask people here to give us a talk. Okay. Any other question? Any hot question?
Assalamu alaikum.
Your name, please.
Mahmoud Shehata from Aswan Heart Center, Alghafoud Foundation, Egypt. I think when we talk about the pulmonary valve implantation, this is the usual debate. It's surgical, it is percutaneous. We have started this program 2020 during the COVID era. We now almost implanted around 40 valves percutaneously with different platforms. With this short-term experience and follow-up, what I'm getting is, are we going to go so young to put the percutaneous valve, or we are waiting too long time to put a percutaneous valve? I think, as the panel said, that the follow-up, the volumes, the symptoms, that consider when to the best time to do pulmonary valve replacement, whether it is surgical, whether it is interventional. It's about the patient benefit. It's not about the route of implantation. As the doctor mentioned, also if you start very young, putting melody valve, we know that the melody valve, the maximum size is 24, and this getting calcified faster in the young children rather than the adults. So we are starting the cascade of like 4 or 5 valves need to be implanted. If you put the first valve when the child is 10 years old, so you need at least to be 60, you need like 4 or 5 valves to be implanted. So sometimes when you started early with a percutaneous management, you put suboptimal dimensions. So you need to get this conduit bigger, and if you put 1 or 2 valves, so the pre-stenting, so you get the whole assembly as complex, and you make the surgical options also a bit difficult, because you now almost replaced the native pulmonary valve with a stent, so you need to get this whole thing out. So rather than putting a short tissue valve inside a native pulmonary valve, you need to externalize all the things, and you need to go back for the contegra or homografts. So I think they need some wisdom to choose when to use the percutaneous pathway, when to use the surgical pathway. It depends on the anatomy, it depends on the size of the patient, the age, and also as all people accepted the follow-up, because maybe the percutaneous approach is still recent than the surgical approach. But also we have seen the tissue valves degenerate early. even the surgical valves, the conduits. We have been using homografts, freestyle, Contegra, whatever the surgeon put in the RP2P conduit. So I think like all people accepted, that you start first to have the registry. You collect your patients, do the exercise of imaging, see the prioritized who's need first. If you are talking about young adults, 24 years old with free pulmonary regurgitation, you have already a dilated annulus, so you can put with the new self-expandable valves up to 36 millimeter valve, which is a very big valve. So and the first one implanted 2013, now it's 10 years follow-up, is doing fantastic. So I think also it's about the size of the valve that's implanted. If you implant a big valve, so the degeneration, the calcification is much lower than if you implanted a 20 millimeter valve and the age of the patient. The other thing that we are not sure about the anticoagulation or the antiplatelet regimens after that. So now the surgeons start to reconsider giving anticoagulation for like 6 months first after tissue valves, and then consider aspirin whether for 1 year or for life. This might help avoid the thrombosis of these valves and degeneration.
Thank you.
That's my view.
Thank you. I think we'll leave this discussion and the talk later on today, because we have many information from what this is as well. So we need to move on to the next speaker. I think Dr. just for commenting, in Egypt, the delay in the percutaneous pulmonary valve implantation, although they only started a few years ago, but I'm aware of, it should be started a long time ago, but in Egypt, which is compared to the other region in the Arab countries, like Saudi and the Gulf, who started a long time ago, the flow of patient is too high in Egypt. Like I understand this is financial issues more than anything else. When you talk about 30 to 40,000 euros for device, it makes a lot of changes in developing countries comparing to the countries who have the facilities. Not underestimate any activities or scientific direction in Egypt, but I'm talking about Egypt. They are very late in the implantation of this valve due to that reason. The whole financial, more than anything else, who's supporting the service. Although this only started a few years ago. I attended one meeting in Cairo. The first case was in Egypt. Okay, we are ready.
We present Dr. Atafi al-Mutwalli, Professor of Cardiac Surgery and Head of Cardiac Surgery Department, Tanta University Hospital, Egypt. Talk is RV to PA connection. After a gene strip, did we reach the optimal option? Dr. Atafi.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. Of course, it is a great honor for me to be invited for the Libyan Cardiac Society meeting. مع الكوكبة دي من الأطباء القلب وجراحة قلب الأطفال في ليبيا. المحاضرة ممكن تطرش جزء من our discussion now.
هو السيشن بتاعنا كمان. هو السيشن بتاعنا كمان بنحط 10 وربع. ونحن ما كملناش 2 سبيكر. والله ما يعرف. طيب عندك ولا هم يغيروا؟
لا
بيعرضوا حتى ساكت
عندك جزيء موز.
الشغل الشديد اللي بتعمل الشغل
يا ريتني جبت ولدي والله. جبت ولدي
اي منهم؟
على الاي تي. لا بس هو صغير. يا
بس بتاع نيويورك اوكي.
كان جيب بتاع نيويورك.
بتاع نيويورك.
اصغر واحد اي تي الوحيد اللي اذكى واحد فينا طلع مش طبيعي. اذكى واحد في العائله.
ابدا دكتور.
بس يبدأ سنين طيب بس
جالس صار دكتور عطاك.
هو احنا المفروض نتكلم على الرايت ventricular pulmonary artery connection after a genius trip. Did we reach the optimal option? وكان الاستفتاء واضح من قبل المحاضرة انه إذا
لحظة.
راح لنا السلايد لو سمحت. فول سكرين. لحظة.
لا تحرك.
ديروا فول سكرين.
نحاول.
السكرين هي اللي تلخبط. نحطه فول سكرين. خليتني ماشية.
فول سكرين
طلع في الستريس.
فول سكرين. There's no conflict of interest. احنا هنعمل RV to BA connection in which cases sometimes you have an absent right ventricular outflow tract like pulmonary atresia or truncus arteriosus. Sometimes you have the RVOT but it is unsuitable like in cases of detransposition VSDBS or LTG-ABS or some complicated dwarf. Or it be iatrogenic زي في حالات الرص ناخد البلمونري اوتوجراف ونستيد ونبليس الكوندويت فروم ذا بالمونري دي الحالات اللي هحتاج فيها RVBA connection. Certain criteria should be available for an optimal conduit. Should have a long-term patency, available in all sizes, good handling characteristics in surgery, long-term valve function, gross potential, low cost, low infectious potential, and no need for anticoagulation. The story started from Herbert Sloan in the early 60s. He was the first reported conduit, subepicardial tube between the RV and the pulmonary artery in a case of truncus arteriosus. Then this is the legion who never operated, Carlo Rostelli. He was a young Italian guy that worked as a research fellow in Mayo Clinic with John Kirkland. He died at 37 years from lymphoma. He never operated in the operating room, but he has a proposal of the conduit to John Kirkland, and they used the cardiac tube in a case of pulmonary atresia. It was in 1966, and since that time, it bears the name of Rostelli. So any connection between the RV and the pulmonary artery, it's called Rostelli connection. Then the godfather of homograft is Donald Ross, who invented the Ross operation, putting the pulmonary autograft in the aortic position and a conduit homograft in the right ventricular outflow tract. The surgical options, the spectrum is very large. So we have valve conduit, valveless option, or pulmonary valve replacement. For the valve conduit, we have either homograft, xenograft, or manually constructed conduit. For the valveless option, we have a non-valve conduit, non-conduit repair. For the pulmonary valve replacement, we have either surgical or interventional. The homograft, we have either aortic homograft or pulmonary autograft, or pulmonary homograft. For the xenograft, either stentless, like the bovine jugular vein, this is the contegral, the porcine aortic root, which is the freestyle. We have the stented prosthesis, the Hancock valve. The manually constructed, either composite, whether prosthetic or bioprosthetic valve in a synthetic tube, or autologous, the valved pericardial tube. For the valveless option, we have either non-valved conduit, either native with a valveless pericardial tube, or synthetic like Dacron or polytetrafluoroethylene, the cortex. For the conduit repair, we have some procedures like reef operation, after truncal switch, or pure-marshal operation. For the pulmonary valve replacement, either surgical or interventional, we have the tissue valve or mechanical valve or transcatheter pulmonary valve implantation. This is the spectrum of surgical options that the surgeon has. As regards to the homograft, we have either the pulmonary homograft or the aortic homograft. What's good and what's bad? For the homograft, they have a good long-term valve function. They have a good handling characteristics, no infection potential, no need for anticoagulation. On the other hand, it's not available in all range of sizes, no growth potential, and very costly. Comparing the aortic and pulmonary homograft in the pulmonary position, they have the same survival, but the incidence of calcification and obstruction is more common in the aortic homograft in the pulmonary position. For the xenograft, we have either the contegra, which is the bovine jugular vein conduit, or the freestyle valve, which is the porcine aortic valve. They are also available in a wide range of sizes, good handling characteristics, no need for long-term anticoagulation, ممكن for short-time anticoagulation for 3 to 6 months, but they have no growth potential, they degenerate over time, and they are costly with high infection risk, especially with the contact. As Thomas Bremen stated that in 4-year follow-up, the contegra is a valid alternative to homograft for pediatric right ventricular outflow tract obstruction. This is a study come from the group of professors in Saudi Arabia, and they found that the age, the younger age and the male gender is associated with graft-related events more higher in male gender and in young age. The stented xenograft is the Hancock aortic valve. When it is introduced in the market, it was available in a very range of sizes, small sizes, even 12, 14 millimeter. And it has many good characteristics, availability, good handling, low infection risk, no need for long-time coagulation, and cheaper. But still, there is no growth potential and calcification and degeneration over time. But it offers primary repair rather than palliative for many lesions at that time. For the manually constructed, we have either the composite prosthetic valve in a Dacron tube or bioprosthetic valve in a Dacron tube, which is available, low infection risk, long-term durability, no anticoagulation if prosthetic, or cheaper in cost. But there's no growth potential. Dacron is rigid for handling, calcification, degeneration if bioprosthetic valve is used, and long-term anticoagulation in mechanical valves. But in resource-limited countries, as Dr. Salim said, you may need this low-cost conduit for the RV-BA connection. For the manual constructed autologous, we have the pericardial tube, valved pericardial tube, which is available with low risk of infection, mid-term durability, only short anticoagulation, cost, of course, of no cost because it is taken from the patient, good handling, but there is no growth potential and degenerate over time. But again, in countries with low resources, you may have these options, the momentarium of RV connection. We have the non-valved conduit, either native with Vortex or Dacron, or pericardial tube, non-valved pericardial tube, which is available, low risk of infection, long-term durability, no anticoagulation, cheap, with good handling characteristics, but still we have the issue of the growth potential, and it is a valveless option. And when you choose between the valved conduit or the valveless conduit, you are choosing between valve competency with higher rate of reoperation, or you choose to protect the right ventricle from the pulmonary regurgitation at the expense of low rate of reoperation. Non-conduit repair, REEF procedure, réparation l'étage ventriculaire, invented by Lecomte in 1982. He used to baffle the VSCD from the left ventricle to the aorta and direct the connection of the pulmonary artery to the right ventricle with transannular patch. There is an Ecaido operation that is to transfer the aortic root back to over the left ventricle and making the Lecomte maneuver to bring the pulmonary in direct connection with the right ventricle with mobilization of the proximal coronary arteries or re-implantation. The Porpiro-Marshall technique, this technique is used for truncus type 1 or maybe type 2. It mimics as if you are transforming the lesion like a tough repair with transannular patch. You make a posterior wall of the connection from the wall of the trunk and the left pulmonary artery, then make a transannular patch over the right ventricular outflow. When comparing this maneuver for the ventricular function, we found that the REEF and the Kaido tends to offer better preservation of the ventricular function. In the long run, compared to